So, as I said, we're going to be going through SBAs in elderly care for finals, UKMLA summatives, however you want to call it. And just to go through sort of the main topics we're going to be covering, we're going to be going through pharmacological considerations. We're going to go through collapse and falls. We're going to go through infections in the elderly population, some hematology, some renal medicine, delirium and confusion, and a couple of other things. And one of the good things about Jerry's as well, if you haven't had your placement, that is that it's it's very gen medi. And what I mean by that is it brings together a lot of the core content that you've probably already learned, and that's why it's also a good opportunity to try to cover these things. And as I'll always advise, if you see patients with particular conditions, that's the best way to actually learn them, because it creates more links in your brain when you're trying to trace back that information. So do go in for your Jerry's placements if you want, because you'll see some really interesting cases and see some interesting signs as well. In some of your Jerry's teaching, you might have come across the geriatric giants before. It's quite a dated term, but what that essentially covers are falls, iatrogenic disorders, so things that are, for example, side effects of medications, incontinence, confusion, and impaired homeostasis. So these are all quite broad things, but they cover essentially the main sort of conditions that we see in the elderly population. And what I hope you take from this is that, in elderly care, we take a very holistic view, and some of these are actually based on scenarios that myself and colleagues have faced in practice. So without further ado, we'll start with the first SBA, and a poll should, yep, now. And I'll give about a minute, 50 seconds to a minute per question. But as always, we have quite a bit of questions to go through. Okay, and I'll stop the poll there. So we've got a bit of a mix between A, B, and C. So what we have here is someone who's coming in with increasing frequency of falls. We think that there may be an element of postural hypertension, maybe from some of their observations. And she's not on any medication that appears to be causing it, and she's also euvolemic as well. And the answer here is actually C. So with any condition, any disease, any approach to a patient who's presenting with symptoms that are being problematic, is the main framework that you should be using is going from whatever's sort of the least invasive to then the most invasive. So the way I see that is you go for sort of conservative management first, then medical management, and then, if indicated, surgical management. So to go through postural hypertension, and I'll go through some of those other options, but essentially midodrine and fludrocortisone are two medications, and abdominal binders is something that you can wear, which isn't used so often now, but used to be. So the main things to take away from this slide are sort of the definition of postural hypertension. I definitely remember finals questions where there was either asking for what the definition was, like what the drop was, for example, or it would give a patient with some OBS, and then the 5 options would be examples of blood pressures, and it would be like, which of these would be indicative of postural hypertension? So we've got the definition up on screen. It's really important. It's something that occurs very, very frequently in the elderly population, and it's linked primarily with sort of causes behind falls. When patients are hospitalized, that's something that we regularly check. And especially when it comes towards the end of their admission and we're readying patients up for discharge, it's something that you always want to check as well, especially because as an inpatient, you're not as mobile and you may not be getting up and walking around as much. And I've also put on the slide how to measure it as well. So in terms of people who should be monitored, essentially most elderly patients should, and in particular, everyone with Parkinson's should get a lying and standing blood pressure. And the reason for that is because patients with Parkinson's are more likely to have autonomic dysfunction. Other indications include people who have had a fall or an episode of syncope, patients who as you'll see, are on lots of medications, as this population is, and also patients presenting with dizziness. It's something that's really easy to check and potentially quite easy to manage as well. So in terms of managing postural hypertension, as we said, you want to go for conservative management first. So if there's any medications that you think are causing it, for example, something like tamsulosin or sometimes diuretics, if there's any possibility to sort of tinker with these doses, especially because in the elderly population, we try to reduce that pharmacological burden. And definitely when I was working on Jerry's and lots of patients would come in on 10, 12 medications, often one of the first things my consultant would do as soon as they had been admitted is go through the medication list and go, nope, don't need it, don't need it, don't need it. Especially because a lot of these medications, they may have been started on for prognostic purposes. But for example, if it's a 95-year-old, a statin isn't necessarily going to do much because, the use of statins is based on a 10-year plus risk. And, in that population, with the side effects being more likely, most would argue that actually it's not that useful and just increases that pharmacological burden. So we've talked about sort of non-pharmacological things, so lifestyle measures. So there's some evidence that talks about increasing fluid intake, and salt intake is there's not as much evidence for, but definitely fluid. So making sure that you're not dehydrated and that you're drinking enough water. Exercise and staying mobile. And then moving on to step 3, there's some medications that can be used. And the interesting thing is actually there's no sort of unifying guideline that actually concretely says, you won't find a nice guideline or clinical knowledge summary that says use this, use X, use Y. But what they do say is that expert advice recommends for the usages of various medications. And most commonly, that's fludrocortisone. The other medications are not so commonly used. I think it's actually more of a cost slash post-Brexit thing is the reason why midodrine's not used. And primarily what you'll see in the UK at least is fludrocortisone use. And essentially what that how that works is by increasing your fluid reabsorption. And there's a couple of quotes there from the European Society of Cardiology. And as I said, it's based on expert opinion. And we have the next question. And as always, if you have any questions, feel free to drop them in the chat or in the Q&A section. I'll try to go through them as we go along. But if we're tight for time, we might have to wait until the end. And similarly, the single most common question we often get is, are the slides available? Will this be recorded? The answer is yes, this is being recorded and it will be put on our YouTube channel, QuesMed Tutorials, tomorrow. Okay, and I'll stop there. So most people went with B, which is indeed the correct answer. So we have a patient here who suffered a fragility fracture, which essentially is any fracture that very sort of minimal force is required, and it means that someone is more vulnerable to them. For example, if they're postmenopausal or suffer certain endocrinological conditions. And what that means is, I know this is a bit arbitrary, but the way it's defined is that if someone has a fracture from the equivalent from a fall from standing height or less, and I'm not going to ask anyone to do any demonstrations here, but as you can appreciate, that's not a lot of force. And in this particular age group, so over 75 years of age, the guidance is that they don't actually require a DEXA scan prior to starting secondary preventative measures. And the most commonly used first-line agent for that are bisphosphonates. Alendronate is one example of this. And one of the things that when I was preparing the slides is there's not really sort of a national unifying guideline in men. But generally, you would apply these same principles too. And for that reason, I've also included, I don't think that you would necessarily be examined on that because it's not exactly clear. So to talk about osteoporosis for a bit, the main scoring calculations that we use are Q fracture, which is more recent, or FRAX, which I'm sure some of you might be more familiar with. They use it quite a lot in GP. And the patients you want to screen for this are all women over 65, men over 75, and younger patients if they have any risk factors. So those that are on prolonged steroid courses. So for example, patients with inflammatory bowel disease. And what these scoring tools do is they look at the 10-year fracture risk. And if there's a certain score or a certain threshold is met, these patients will have a DEXA scan, which can provide more information. But as we said, in certain populations, such as those over 75 and having a fragility fracture, that's not required, and you immediately start secondary prevention. And the main T-scores you want to learn are these two, because again, it's a very common question where there'll be a patient stem and it will say their T-score was this, what would you do? In terms of managing osteoporosis, I know this is quite a busy slide. Again, we want to use that same model of conservative and least invasive first, and then you move on to medical management and other measures. So in terms of lifestyle interventions, again, if you came to my lecture last week, stopping smoking, smoking cessation is the answer for anything and everything. Alcohol excess is quite a big risk factor, and also mobility, because the less you move, the weaker your bones become, especially in the elderly. Vitamin D replacement is very important in these patients, and you'll see that pretty much anyone coming to hospital is either started on vitamin D or they're already on it, and that's because in the UK, we don't get much sunlight here. In terms of primary prevention, the most common first-line agent, as I said, is are bisphosphonates, and these work by inhibiting osteoclasts, which are responsible for absorbing and breaking down bone. And one of the important points here, especially for your PSA exams, the prescribing safety assessment, is that patients need to sit upright for 30 minutes after taking it. That's because if they don't, it can cause really severe reflux, which is obviously very uncomfortable and is one of the most common causes of non-compliance with this medication. Denosumab is a monoclonal antibody, which is often second line because it's very expensive. And then in terms of other options that we have, raloxifene and teriparatide, these are sort of third, fourth line agents, and you don't need to know a lot about them. I've only put their mechanisms here for completeness. And of course, hormone replacement therapy in women who are eligible for it. Here we have the next question. Great. So the majority of people have gone for A, which is indeed the correct answer. So we've got an 81-year-old who's passed out or fainted and is unable to sort of recall the events. They've denied any in particular sort of red flag signs, such as palpitations. Other things you want to look for are weakness and chest pain. He's on quite a few medications, the common medications that we expect, and there is no evidence of any postural drops. On examination, we find an ejection systolic murmur, and it's radiating to his carotid arteries. So the condition that we're thinking about that may be causing this is aortic sclerosis. Now, falls is a huge topic. And again, when it comes to elderly care medicine, we use a holistic approach and we consider essentially every organ system. So as a broad framework, things that you want to look at. Number one, when the patient is presenting to you, are there any complications of falling? So have they presented with, an injury to their head, most importantly, but also to any of their bones? Could there have been a fracture, neck of femur fracture, for example? Then, in terms of the causes, things you want to think about primarily are cardiac causes and neurological causes. And the reason that I've put on the side here, did they fall on their face, is because, again, if you've ever had a fall before, a lot of the time, say, for example, on a sports night, late evening, you'll often break your fall. And what I mean by that is you anticipate that the fall is coming. Now, if a patient falls on their face, that actually suggests that, they had very little to no warning. And that's more indicative of cardiac conditions. So things like heart murmurs, aortic stenosis, aortic sclerosis, and also arrhythmias. In terms of neurological differentials that we need to be aware of, we primarily think of things like, is there a stroke? Could it be a seizure? These are relatively common causes, or at least the serious ones. And again, things that can cause a patient to feel very uncomfortable. So things, if they've got abdominal pain, either from constipation, obstruction, or urinary retention. We've talked about postural hypertension and how important dehydration can be in causing that. And then also peripheral neuropathy. So you're thinking about your patients maybe who have suffered diabetes for a long time and have suffered some of those microvascular complications. So peripheral neuropathy in a sort of glove and stocking distribution will mean that they have reduced sensation and hence are more likely to fall. And again, very easy, very simple. Are they wearing appropriate footwear? Are they wearing shoes that don't fit them, for example? And then lastly, at the bottom, worsening of any chronic medical conditions. So things that can directly impact your motor function, like Parkinson's, and then also things that can impact your cognition, such as in dementia. In terms of investigations that you want to do in a patient who's either collapsed or fall, these are the main things. And again, we want to use that same sort of approach of either bedside and conservative measures before moving on to slightly more invasive things like a blood test or other investigations, and then imaging. So in terms of observations that you want to look at, we talked about blood pressure, we talked about checking for lying and standing blood pressure. Other things that can be done at the bedside are urine dips. Key caveat here is there's certain populations where this isn't as useful in. So in the over 65s and in patients with long-term catheters, for example, urine dip is not that useful. It's almost essentially always going to show that there's leukocytes present. And in these patients, you want to go off of either their clinical presentation, so their symptoms, as well as urine MCS. So you should still send off that MSU MCS to try to grow any bacteria. PR exam, extremely important to rule out constipation, because also constipation is a very common cause of, it can lead to UTIs, which can lead to a delirium, which can lead to a fall. And that's why I want to do a bladder scan as well. Very simple, can be done at the bedside. ECGs, we're looking for arrhythmias, any evidence of any cardiac events, and a chest X-ray looking for infection. If they've suffered a head injury or they are on, for example, anticoagulation, you may want to rule out a brain bleed. And also, obviously, if you're suspecting a stroke. 24-hour tapes, this is something that you may do, not necessarily in the acute phase, but you might do as an inpatient or something that a GP might recommend. And further to that, we have an echocardiogram to look for any structural abnormalities, things like aortic stenosis, aortic sclerosis, and then more specialist tests we mentioned, things like a cardiac angiogram, coronary catheters. These are very invasive things that you don't immediately think of, but may do later down the line. And when you do become doctors, please do not put smell strongly of urine, plan nitro, please. Now we have the next question. Okay. Sorry, I left that for a bit longer. I was just going through some of the questions there. So just to summarize that, actually, so someone's asked, before prescribing alendronate, shouldn't the hypocalcemia be corrected first? And you're absolutely correct that any modifiable risk factors should be managed. But in that cohort of patients who are over 75 and having a fragility fracture, the evidence still recommends starting them on a bisphosphonate. And then someone had a question about a tape, and it's think of it as an ECG, and we're looking for any arrhythmias, and they can be anywhere from 24 hours to 7 days or even 1 week. So we've got a bit of a spread of answers here, and the answer is dehydration. So as I've mentioned so far, this dehydration is very common in the elderly, and it's something that's very easily correctable. And this is a patient who's been suffering some weakness and some dizziness as well. And they've got hyponatremia, so low sodium, which is the next topic we're going to talk about. And I'll try not to dwell on this too much because, again, it's probably going to be covered in our endocrinology lecture. But again, it's something that you see very often. And I thought it would be good to just run over sort of, again, another key framework to how to look at it. And that's essentially by going off of fluid status. So we can split it up into hypovolemic, euvolemic, and hypervolemic. So as you should be preparing for your OSCEs or CPSAs, you should be going through a fluid status examination because that's something that can come up. And have they got signs of dehydration? So things like increased skin turgor, for example, is the skin drier? Things that can cause a hypovolemic hyponatremia most commonly are things like diarrhea, vomiting, things that are going to make you lose fluids quite a lot. Fistulae as well can cause lots of loss of liquids. And then we also have burns and Addison's disease, which are slightly rarer causes. If they're euvolemic, so they appear relatively well hydrated, then our favorite thing to go to is SIADH, but also a slightly less common cause is hypothyroidism. And that'll be relevant when we talk about some of the investigations that are done. And then lastly, if they're hypervolemic, so these are, I think these are the failures. So renal failure, heart failure, liver failure, and then nephrotic syndrome failure. In terms of the investigations you want to do, this is probably more of a real life point rather than necessary for your exams, but it can come up, what investigations would you want to do? And essentially it's these 5 primary things. So you want to do Urinary to confirm the hyponatremia. You want to do urine and plasma paired osmolality, and if they aren't on diuretics, that would be more ideal, but if they are, that can sometimes impact the results. You want to look at the urine sodium, again, preferably if they're not on diuretics. You want to do a urine dip to look for things like proteinuria, which may suggest a glomerular pathology. And lastly, as we were talking about, rarer causes being hypothyroidism and Addison's disease. So you want to check their TSH and morning cortisol as well. I know hyponatremia can be quite tricky, but that's sort of a broad framework that you can use to approach it. Okay, so most people here have gone for D. So we've got a patient who's come in complaining of pain. They've gone on to have a seizure. Now, again, the point here is slightly academic and slightly arbitrary because if someone's coming to A&E and they're being given analgesia, the first line thing is not tramadol. And I hope this definitely wasn't a real life scenario when I said that some of these are influenced by those. Tramadol would only be suggested by someone who didn't pass their PSA maybe, or is a non-prescribing person. So they're found by the nurse seizing. And what I want to talk about here are medications that can reduce seizure threshold. Because again, these are very important. Now, the main medications that are sort of most commonly used that can reduce seizure threshold are antipsychotics like haloperidol and antidepressants, in particular tricyclic antidepressants. With antibiotics, it's slightly less common. You'll see it listed as a side effect on the BNF, but very rarely do you sort of, especially in practice, see a patient who has a seizure and the cause of it's given is due to antibiotics. It does happen, but it's not super common. And then we've got some other opioid analgesia. So we've got lidocaine there. We've also got fentanyl, and then also lithium. Now, and then this is the comment from a very, very common scenario where you'll be on call at night and someone will call you about a patient who's being very disruptive, and you shouldn't just prescribe remotely. Obviously you assess the patient and then you decide what's most appropriate. Right. And just before I share the answer, we had another question saying, for the management of hyponatremia, would you always treat the cause or consider giving some saline? I think the clues in your question there, you'd always want to treat what you think the underlying cause is, because if someone's got either a euvolemic or a hypervolemic hyponatremia, then simply giving fluids won't fix that. And especially when it comes to giving actual sodium replacement, it's number one, you sort of have to consider how quickly you're replacing the sodium, because as some of you will know that if you replace sodium too quickly, it can cause central pontine demyelination, which isn't good. So we've got a patient here who has got some kind of delirium or acute confusion following some medication that's been started for hay fever. And correctly, the answer is chlorphenamine, which is a first-generation histamine antagonist. And next, we're going to talk about sort of polypharmacy and important side effects of certain medications, and in particular in the context of delirium. So benzodiazepines, very commonly used, especially if someone's been given some lorazepam, for example, if they're being very agitated. Whilst that will calm a patient down, it can also make them quite loopy. And in particular, you're worrying about things like respiratory depression if they're having repeated dosages. We talked about opiates. They can not only cause confusion as quite a common side effect, but they also very commonly cause constipation. I'm sure some of you may have had, for example, a bone broken before or been in pain for one reason or another, and you try taking codeine, cocodamol, it'll bung you up. Drugs used in Parkinson's and tricyclics in particular. These can be very dangerous in overdose. Tricyclics in particular, so things like amitriptyline, can cause a variety of sort of rhythm disturbances, arrhythmias, which can potentially be fatal. Same is true for digoxin as well. Beta blockers, the reason beta blockers are there is because actually they're quite commonly taken, obviously, by lots of patients on medication. But in particular, if a patient is confused or they've got dementia and they accidentally take an overdose of beta blocker, that can obviously cause a very serious bradycardia. And the treatment for beta blocker overdose is actually glucagon, which I always thought was quite interesting. I don't know the mechanism for that, so don't ask me. Steroids can cause there's obviously well-documented steroid-induced psychosis, and as part of that, these can cause quite vivid hallucinations. And as the question mentioned, antihistamines, first generation antihistamines such as chlorphenamine. And at the bottom, they're very important. Alcohol, old people drink too. So always ask that in your history, because especially what may be normal for them may actually be excessive, and they may have been doing it for a long time. Which is why you also want to think about things like optimizing their nutrition, in particular vitamin deficiencies, and also the consequences of that. So as we know, that excessive alcohol consumption can also lead to peripheral neuropathy as well. And this is why polypharmacy is extremely and increasingly important and becoming more and more more and more worse in an aging population, as you can appreciate. Okay, so majority of people have gone for E, a few people have gone for D as well. And what we have here is a patient who's complaining of visual hallucinations. Very importantly, they have insight, so they're aware that they're not real, but they're very vivid and they're obviously troubling the patient. Also very key is that the patient is also blind. So the answer here is Charles Bonnet syndrome. And this is, I've never seen this before, but for whatever reason, SBA's finals love asking about this. Just to go through the other options quickly, hypnagogia is actually a normal phenomenon. It's where either just as you fall asleep or immediately after waking up, you can have hallucinations. There isn't anything to suggest this is schizophrenia because often these patients won't necessarily have insight. Lewy body dementia is commonly causes hallucinations in these patients, and there may be an element of dementia here, but this most commonly also presents with motor symptoms which aren't present. So Charles Bonnet syndrome essentially only impacts people who are blind. So patients with cataracts, for example, bilateral cataracts, and what they see are very vivid hallucinations, which is why they'll describe things like animals, and they'll be, as I said, one of the keys here is that they have insight into them and they know that they aren't there. But yeah, exams love asking about it. Now, going through a confusion screen, again, you want to look for very, very common causes of confusion and delirium. So we talked about urine already. In terms of bloods, so anemia is very common in the elderly, and sometimes that can be a red flag for particular malignancies. CRP can help in looking for infections, and sometimes an ESR is helpful if you're thinking of other hematological or rheumatological differentials. We've got thyroid function tests and calcium levels. In general, sort of electrolyte abnormalities tend to be more common in the elderly, especially if they're, not maintaining good nutrition. But also just as your renal function declines with age, and that's why we have renal function there. B12 and folate, we've already talked about importance of nutrition. And liver function, we're not necessarily thinking about encephalopathic features, but liver function does also decline with age. In terms of more invasive, more specialist investigations, things like a CT head or an MRI may be done. LPs, sometimes not that often. And then even more rare are EEGs or electroencephalograms. So in terms of dementia and the main differentiators between sort of the main dementias, so Alzheimer's disease, the most common type of dementia, and there can be sort of not necessarily a sudden onset, but it tends to be more insidious. So, it doesn't come as an expected presentation, for example. And it can cause very often things like difficulty finding your words. It can result in wandering, as well as behavioral symptoms and psychiatric symptoms. In vascular dementia, there tends to be more of a stepwise decline of cognitive function. And these tend to be patients who have, for example, maybe had multiple strokes, or have lots of risk factors for sort of very, very small ischemic infarcts that, with time can sort of build up and cause dementia. Lewy body dementia, we talked about briefly in the previous presentation, in the previous question. Very sort of, to simplify it, you could think of it as Parkinson's with dementia, because they tend to have these motor symptoms demonstrated in their Parkinsonism, but they'll also have visual hallucinations. Frontotemporal dementia often results in behavioral changes that are typically associated with the frontal cortex, so your executive function, so things like impulsive actions, things like gambling, sexual disinhibition. And there's quite a few genetic links with FTD, so it can sometimes present younger as well. And also, actually, very importantly, in Alzheimer's disease, patients with Down syndrome can present with Alzheimer's very young, actually, so in their 40s to 50s. And then we have pseudodementia, which is a bit of a gray area and obviously slightly difficult, a bit more difficult to diagnose, and is more of a diagnosis of exclusion. So things like depression is very common, unfortunately, in the elderly, especially, where loneliness can be a factor. And so that's also, you always want to think about your other differentials. If you see an elderly patient who may be slightly confused or they're having memory issues, don't always just jump to dementia. Think about the other factors and some of the things we talked about in the previous slides that you would test for. Okay, so we have a bit of a spread between the answers here. And what we have here is a patient complaining of various signs and symptoms which are suggestive of a pancytopenia. And it's interesting that we have a split between C and E here. So bone marrow biopsy and a blood film. And again, the point here is slightly arbitrary because if this patient came in and they had a pancytopenia, as you might know, a blood film is normally automatically added on by the hematology lab. But again, this is to emphasize the point which I mentioned earlier, is we go for the least sort of invasive and more conservative actions first. You're not going to go straight into a bone marrow biopsy on this patient because that's a very invasive procedure. Something simple, such as a blood film, can actually reveal very, very important abnormalities that suggest some of the various differentials here. So we're going to talk about one of the commoner hematological differentials in elderly patients, and that's myelofibrosis. It's also called myeloproliferative disorder and also marrow fibrosis. And as the name suggests, you essentially have fibrosis in the bone marrow. What that means is that the bone marrow is less functional, and that's why we have a pancytopenia. So that means low cell counts in red blood cells, white blood cells, and platelets. Common presenting signs are things like weight loss, fever, and night sweats, which is why malignancy is also an important differential, sorry. And as we mentioned, some of the stigmata of that pancytopenia can be, for example, recurrent infection, anemia, and also easy bleeding or easy bruising. Splenomegaly is common, and it's one of the main, I think there's 5 main causes of splenomegaly, of which myelofibrosis is one. Sometimes you can get an enlarged liver or hepatomegaly with that, and sometimes you can get a hepatosplenomegaly, so both the liver and the spleen enlarged. In terms of the keywords that you look for in a blood film report, you're looking for poikilocytes or tear-shaped red blood cells. And the classic sort of single best answer exam question finding is that there's a dry tap when they try aspirating the bone. The reason it's dry is because there's so much fibrosis. And again, just to go into anemia in the elderly, which is again very common, commonest causes are common. So iron deficiency, we've talked about B12 and folate deficiency. That can be caused or exacerbated by alcohol excess. Patients with chronic kidney disease may have anemia of chronic disease. We've talked about myelofibrosis. Myeloma is also very common with age, and it's good to learn the CRAB mnemonic for that. And then lastly, another malignancy, which is CLL. And from this blood film, does anyone know what can be seen here? If you don't mind just putting either in the chat or the Q&A. Okay, so what this is showing actually, if you can see my mouse here, these cells are known as smudge cells, which are very common in CLL, which was the chronic lymphocytic leukemia, which is the last differential here. stop it there. So the majority of people have gone for either C or D, so trimethoprim or gentamicin. It's interesting that more people have gone for D here, because I think one of the keys in this particular question, again, is actually reading the exact circumstance here. So we've got a patient that's presented in GP clinic, and they're presenting with signs and symptoms of a UTI. Gentamicin would not be given in GP. It wouldn't be given as a 3-day course, and it's not an oral medication. It's given either intravenously or in ear infections, ear drops. So immediately, actually, you would rule out tazocin, gentamicin, and meropenem based on that. You're then left with A and C, so amoxicillin and trimethoprim. Amoxicillin is sometimes used to treat UTIs, but it's often a third line or sometimes used for UTIs in pregnancy. And so actually by elimination, actually, and just going through a bit of exam technique, you would only be left with trimethoprim, which is the right answer. And the phenomenon that this is describing is actually a pseudo-AKI. And the reason why this is important is because, again, you'll see UTIs in the elderly a lot. And depending on the local guidelines, the hospital guidelines, they'll be treated with either trimethoprim or nitrofurantoin. Or obviously, if you have sensitivities, you can give something more specific. But what trimethoprim can actually do is it inhibits the secretion of creatinine. And what that means is it falsely raises it. And so this is a patient, who doesn't actually have an AKI, but trimethoprim has caused this blood level result, which may suggest it, which is why it's important to bear in mind. And again, we've covered a few medical specialties here. We talked about hematology a bit earlier. We'll talk a bit about renal medicine now. So we talked about trimethoprim. Again, nitrofurantoin, you need to check patients' GFR, their renal function, because it's not always indicated as well, especially if they've got CKD. We've talked about dehydration and how that can increase the risk of AKI in elderly patients. Patients with existing renal disease, you need to be extremely careful when it comes to prescribing medications, in particular opioids. And you tend to things like, you might think, for example, in most adult medicine, if you're giving morphine, for example, especially in acute settings, you might give 5 milligrams IV. In the elderly, you tend to half most of those doses. So 2.5 milligrams. And if their renal function is so bad that they can't have morphine, you'd give oxycodone instead, which isn't renally excreted. The balance between sort of blood pressure control and falls. So we talked about how diuretics can cause postural drops and therefore increase your risk of falls. But again, you have to be very careful with sort of tinkering the doses and the effects of that, which is why geriatricians are some of my favorite people. They have a really difficult job, and they truly view medicine holistically and will make some of these decisions. It's not, it's one of the reasons I like Jerry's actually is because it's not just, you don't just follow a guideline blindly. You take into account all of the possible factors. And then lastly, renal replacement therapy, primarily dialysis. And again, you want to think about things like quality of life, and also if there's any sort of preferences that have been made beforehand, so an advanced decision or an advanced statement. Okay, we'll stop it there. So most people have gone for B, co-amoxicillin. We've got a patient here who's presenting with signs and symptoms potentially, that do suggest an aspiration pneumonia, and it's asking what kind of antibiotics you're going to give. And B is in fact the correct answer, co-amoxicillin. So aspiration pneumonia, again, more common in the elderly, and the reasons for that are because of some of the causes of aspiration. So lots of people may have had a stroke before. Some patients may have a reduced GCS, or sometimes in their delirium, may have an unsafe swallow. If a patient is post-ictal, Again, they may have an unsafe swallow and also an alcoholics, again, because of that neurological dysfunction. And sort of the main offending organisms are still the same. However, if a patient has aspirated, and what we mean by that is, some of the stomach contents have come up, what you worry about are anaerobic bacteria which live in the stomach, which is why actually, along with beta-lactam antibiotics, so normally something like Carmox, we'll also add on metronidazole to cover for that potential anaerobic cause. And what we have here is a wrongly placed nasogastric tube, which has resulted in aspiration, and this is actually a never event. And a chest X-ray should always be following NG tube insertion should always be checked before indicating it's safe to feed. Because as I said, this is a never event and it can be fatal very quickly, and it's a very common sort of F1 job, or sometimes actually it may be an SHO job, because some trusts have had more of these never events. And sorry about the typo, that should say nurse, not noose. Okay, so we'll stop it there. And again, we've got a slight mix between two answers here, so primarily A and D. So we've got a patient that's come in with abdominal pain, and on PR examination, there is hard stool. They've had an abdominal X-ray, which here we can see essentially this is all fecal matter, and obs are normal otherwise. And the answer is the question is what's the next best step? Now, NG tube and IV fluid, so this is what you may have come across as known as a drip and suck approach. And that's something that we do in patients that we're worried about who are having bowel obstruction. From this abdominal X-ray, there aren't signs suggestive of that. So indeed, the answer is D, which is laxatives. Broad point, something a surgeon told me: when should you not perform a PR exam? I'm sure some of you may have heard this before. There's two reasons: either if you don't have a finger or if they don't have an anus. And having done both a Jerry's job and a surgical job, I've lost count of the number of PRs I've done, which I guess that's not really necessarily a number to be proud of. But it's something that you may be reluctant to do for whatever reason, but it's something that's extremely important because, as I've said, constipation is extremely common in the elderly, and especially as they can quite often be dehydrated. And we've talked about how constipation can itself be quite serious, but can also lead to things like UTIs. And the information that you get from a PR, so number one, you're looking to see if there is any stool. Firstly, if there is it hard? Is it soft? Is there any blood that's present on your gloved finger afterwards? Because this can tell you a lot of information about what sort of the underlying cause may be. And again, we've talked about polypharmacy, we've talked about medications and things like opioids, anticholinergic medications, and also antidepressants, things, especially the tricyclics. These can all cause constipation as a side effect. And for that reason, we have a sort of a basic treatment plan that you would give with sort of a stepwise manner for a patient presenting with constipation. You want to get their fluids up, ensure they're not dehydrated. Typically, depending on the type of constipation, so if there is stool there and it needs to be softened, you may give osmotic laxatives like Movicol or Macrogol. But if it seems very loose, or there's a concern over sort of overflow, you may give bulk forming laxatives. Things like senna is a stimulant laxative, which essentially helps push things along, and that can be given as well if they're still not resolving. And then sort of lastly, you have suppositories and enemas, which, if the medication isn't helping, sometimes that's the next best option. We're almost at the end, guys. I think this is the last question now. Okay. Sorry, I've kept that going for quite a while because actually we've got quite a spread and no clear consensus here. So people have kind of gone for a bit of everything. So we'll spend a little bit of time on this question. So we've got a 90-year-old who's come in with reduced mobility. He's had a previous cancer, which has been bowel cancer, which has been surgically removed. Got depression, diabetes, degenerative spinal disease, and AF. He's restless, and there's a suprapubic mass. So in terms of what's causing this sort of constellation of symptoms, two of the key points here are the fact that there's suprapubic mass and slightly restless. So when you think about things that are in the suprapubic region, especially in a man, you might be thinking maybe it's the bladder. If someone's very restless and they've got a bigger bladder, that sort of makes sense, right? Someone will be very uncomfortable if they've got an enlarged bladder. Is this someone who's got depression and maybe on medication for it? They are. And one of the sort of well-known side effects of amitriptyline is that it's anticholinergic and can cause urinary retention. And again, urinary retention is a very important condition that you'll see in the elderly for a variety of reasons. It may be from an enlarged prostate, for example, but it can also occur as a side effect. The other options here, delirium, is that there isn't so much in favor of that in this stem. Bowel cancer, we know he's already had bowel cancer in the past. You don't tend to get suprapubic masses with bowel cancers. They tend to be more confined to the peripheries. Ischemic bowel, he has AF, which is a risk factor for it. But he's not actually complaining sort of abdominal pain, if I'm not mistaken here. He's got a mass there and he's uncomfortable, and he's restless. But again, less likely. And then morphine, morphine can cause urinary retention actually, but we don't really have a reason for that, for giving morphine at this point in time. So causes of urinary retention. So important drug causes, things like haloperidol, sorry, chlorpheniramine been repeated there. Neurological diseases, so Parkinson's, for example, as we know, can cause autonomic dysfunction. Multiple sclerosis, diabetes, again, through neuropathy, and also any cord lesions. And that's why it's always important to do a thorough sort of abdominal exam. And again, here's an example plan that you may give for a patient in urinary retention. So catheterize them. We need to get that urine out one way or another. You want to monitor their fluid balance, because if they've got a lot of urine in their bladder and they're about to lose a lot, we need to make sure we're sort of replacing that fluid to avoid dehydration and avoid any sort of renal damage. You then may consider a TWOC or a trial without catheter, and that may be done as an inpatient if they're in hospital for a prolonged period, also as an outpatient, often sort of within 1 to 2 weeks post-discharge. you may consider starting a patient on tamsulosin, which can help sort of relax the urinary sphincters. And again, don't forget to do that PR. And then lastly, if you don't really have a cause for that urinary retention, you may get someone from the urology team to review the patient. So that's all the content that we were going to cover today. Thank you for coming and attending this lecture on a Thursday evening. Here's a QR code for the feedback. I can see some of you are leaving now. I'd really appreciate if you could fill out the feedback. Let us know how we can improve. As I said, this lecture is being recorded and will be uploaded to the YouTube channel tomorrow. And if you've missed anything, you can always come back and revisit this. We're doing lectures essentially every Tuesday and Thursday at the moment, and next week we'll have a couple more topics, so keep a lookout. You may have seen that we had a podcast started recently called Quezcast, which again you may find of interest, especially if you're a final year medical student, just to listen to some interesting cases otherwise. If you have any other questions, feel free to either drop them in the chat or in the Q&A. I'll hang around just for a little bit more. But otherwise, again, thanks for coming.